Okay, we'll start the glomerulonephritis and vasculitis session. And we've got a number of cases that we've got from the audience and the case we started with a few minutes ago. So the case presented by Professor Shokr was the case of a young lady with a 1 gram or thereabout of proteinuria. Normal kidney, the creatinine was 1.1 and the biopsy showed membranous nephropathy. And she was treated with steroids and mycophenolate. So the question was, what is the best treatment for this type of patient? Patient with a GFR or creatinine clearance of 54 ml per minute, 1.5 gram of proteinuria. We don't know how progressive it was. We saw her, obviously it must have progressed from a normal GFR to 54 ml per minute, but she may be stable now. Seemingly idiopathic membranous, لغاية ما بعد كده she became a lupus. And I think the very important point Professor Shokr made is the fact that many people with lupus present with a negative serology and don't fulfill the ARA criteria for systemic lupus erythematosus, but very often have a kidney biopsy which is very suggestive of lupus with full house complement deposits and so on, and they go on to develop lupus. So you opted for treating with steroid and CellCept. Just as a general question, is that your standard treatment for idiopathic membranous nephropathy in Saskatchewan?
No, we don't know that, but we have this cohort of patients, young women who wanted to get married, and they look superficially having stable kidney function. So we observe them very closely with this type of immunotherapy and will be ready to use heavy guns, basically. If she was older, had his family already completed, and if we were to know that this is more of an acute subacute course, would have used definitely more stronger immunotherapy. So there was a little bit of bias because she wanted to get pregnant, and that's in my judgment with the main reason. She said, I do not want to take any chance against my potential to get pregnant. But that's not our routine.
So the guidelines, the KDIGO guideline will tell you wait for 6 months on conservative management with ACE inhibitors and so on, as long as the renal function is not declining, as long as the proteinuria is not more than 4 grams per 24 hours, and then treat with a Ponticelli regime. And Professor Fugazi can comment, either alternating cycle of steroid and chlorambucil or alternating cycle of steroids and endoxan. But the point again of Professor Shokr is, like we said yesterday over and over again, treat the patient. Don't treat the creatinine, don't treat the urine. So take the context, pregnancy, young woman, endoxan will not be suitable. Chlorambucil, she's got impaired kidney function, you'll have to consider reducing the dose and the regimen and adjust it and so on. Cyclosporin could have been another option, or a CNI. Again, GFR is 54, which is not a contraindication.
We obviously, I personally do 85% of my time transplantation. So cyclosporin basically is something we are very familiar with. It's used in a variety of things. In general, I shy from cyclosporin. Even if I have to go, I'll go for tacrolimus. I know most of the literature, particularly the old, use the cyclosporin. I'm more in favor of tacrolimus because we believe that it's less nephrotoxic, number one. Number two, your GFR is down. Number three, the more you read about actually mycophenolate, I want you to Google actually mycophenolate and lupus. Even it can be used as basically in the risk management, and it does have an anti-inflammatory effect, very good anti-inflammatory effect. So knowing that the GFR was low, give us a little bit of bias, particularly with the pregnancy issue. But do remember, please, people who want to get pregnant, we maintain them on cyclosporin or tacrolimus. We do not stop them. So just for your knowledge. So that would be a reasonable option. However, we have to keep a close eye on the GFR.
We had Professor Ponticelli with us at the Egyptian Society of Nephrology and Transplantation, and he wasn't very hot about cell sept in idiopathic membranous, at least in European population. He wasn't fully convinced of its efficacy. The impression I have in Egypt is cell sept seems to be... Tita, would you like to comment on cell sept in idiopathic membranous?
I worked with Ponticelli for many years.
Yeah, I know.
So, two comments. The first is that we give Ponticelli treatment only to idiopathic membranous nephropathy, idiopathic, with full nephrotic syndrome. So we don't tend to use corticosteroids or immunosuppressive therapy to patients with 1 gram of proteinuria, of course. But in this very case, I think 32-year-old female with membranous nephropathy, lupus nephritis, this is the immediate connection you have in your brains. And in this respect, I have a question to the pathologist. Was, for instance, the membranous pattern typical, or there were some immunofluorescence findings suggestive of something different from idiopathic membranous? Let's say the presence of mesangial deposits, C1q deposits.
Well, we didn't. Yeah, we didn't do C1q, but even on the base of the immunofluorescence and the light microscopy ones, yeah, it did not strike as being an idiopathic membranous. Again, it's the same thing. You keep looking for clues that would tell you that this could be lupus. She's a 29-year-old female, and she's presenting with a membranous pattern. So yes, she had some mesangial expansion. We'd seen some mesangial deposits, but it was not that conclusive. And also, this is a very important point that yes, I know that lupus should give a full house on immunofluorescence, but day-to-day life, this is not always true. And sometimes it just gives you the regular immunoglobulin and a complement activation. You can find, for example, yes, IgG and C3, maybe some trace of IgA, which you can tend to ignore. It's not always that the case is going to give you this full house pattern, which is going to scream lupus nephritis.
Okay. And for about the question of mycophenolate, in we have good results, controlled results with cyclophosphamide or chlorambucil. So we tend to use either drug. More frequently nowadays, cyclophosphamide, of course, because it's very easy to use. And we use mycophenolate only when we have special situations, such as a young woman who actually desires to become a mother, and we don't want to impair fertility. For young male, what we do is to give sperma in the sperma bank, and we treat them for the correct period, and then we give the full Ponticelli treatment. That is, so mycophenolate is only for special kind of patients. Another problem to be considered, but it is an Italian problem, is that mycophenolate is not in the list of drugs which is delivered without charge from the National Health Service for glomerulonephritis. So we have to fill in a special request, which can be boring and taking time. So first, our guidelines are full nephrotic syndrome, of course, Ponticelli treatment, preferably with cyclophosphamide, mycophenolate only for special situations.
Thank you. Okay. And then the patient became pregnant, creatinine went up to 1.9, and we did another biopsy. And Professor Wissam reminds you all that the classes of lupus nephritis are not stages, so you don't go from 1 to 2 to 3 to 4 to 5. You've got a case here that went from 5 to 4. So the question is, what is the ideal immunosuppression for an active patient with lupus nephritis and aggressive, because the biopsy was aggressive with crescents and so on. Ahmed.
I looked at the program and I knew Dr. Nahas was supposed to give something, so I thought I'll give him a present. That's this case. This woman is in trouble, and this is exactly where prevention is better than treatment. She's in trouble because pregnancy will activate lupus, and if you abort her, it can get worse. So either way, you are stuck, and therefore you are in a narrow area where you have to take a chance, and there will be complications. So the question now is, how much risk you are going to accept? Number one, if you don't treat, she's going to be on dialysis. And just I try to remember, particularly my own students and myself, patients living on dialysis, they do worse than cancer colon. So remember this. So this is a serious issue. We cannot accept that. So number two, is it possible that we can rescue her kidney function and pay the price of pregnancy? Is that a price that we can take? In my judgment, probably that should be the limit of the compromise. So my take home would be to observe her very closely in few weeks with pulse steroid, and if she doesn't get better at all, then I'll use big guns. And in this case, I'll be very prepared that actually we may have to induce her to abort her simply because this is an early pregnancy. And I will warn her that even if we do that, she could be in trouble with a major crisis. Okay, and if she runs into major crisis, then we're talking about big problems and things that we may even plasma freeze her, IVIG, all of those things that we do not usually on routine basis use. But that's what I will do. I'll pulse her, I will increase the steroid 1 milligram per kg and see her on a weekly, literally, or on daily basis, in actual fact, through her family doctor because of blood pressure and so on. With the planning that if she does not improve quickly, then we may have to abort her and use cyclophosphamide.
Why not give her some Imiran? Because Celcept you can't use it, teratogenicity and so on. Imiran is a good drug, and somehow we forgot about Imiran.
Yeah. No, I did not forget about Imiran. And people who have used both drugs as we do in transplantation, I can tell you, Celcept is extremely more potent compared to Imiran. Imiran is non-specific, basically. And I will remain and I will stand correction if there is any report that Celcept is less potent than Imiran. It's the other way around. So, and again, I would remind, because one of the students actually asked me this, the guidelines for pregnancy and Celcept, literally 5 years ago, it was not a contraindication to maintain transplant patients on them. That changed about 4 years ago. And that's because the risk is we took about 1%. 1% of malformation risk on Celcept in this patient is much less than many other things. So Celcept, in my judgment, I'm comfortable to say that would be safe. Whether it's enough or not, that is the issue.
Do you keep your transplant patients on, because we stop Celcept when they become pregnant, we switch them to Imiran.
Absolutely.
So you keep them on Celcept?
No, we don't, because of the guidelines, but those are not having an active disease.
Yeah.
But because we used to leave them and we knew from registry data that the chance is extremely low, then this patient, number one, is education and knowledge. She has to understand that whatever we do, there will be losses. So can we accept this? Yes and no, yes and no. So there is risk of malformation, but the risk in my judgment is small, very tiny, and in my judgment, that would be better than switching her to Imiran. I'm worried she will lose the kidney function, and the patient like this may abort spontaneously because of her inflammation. And if her kidney function does improve quickly with the pulse, she will need cyclophosphamide and be hospitalized, induced under umbrella of heavy immunosuppression.
And don't forget, teratogenicity is during the first 3 months of pregnancy. Yesterday we heard Professor you're worried about teratogenicity at week 28. You don't have teratogenicity at week 28. Any question from the audience about the first case, membranous and lupus, before we move on?
We know that secondary membranous may be secondary to malignancy, and malignancy may be presented many years after membranous. I want to ask if it is really secondary to malignancy, but malignancy not appearing now. What about the immunosuppressive drugs that I will treat the patient with? What's the effect about the appearance of malignancy, and how I can suspect if it's secondary or not?
Right, so they say that membranous can be associated over the age of 50 with malignancy. Malignancy can precede or coincide or follow the onset of the nephrotic syndrome of membranous nephropathy. We're hoping that the antiphospholipase A2 receptor 1 autoantibody may direct us to, but again, it's not entirely specific. So the answer to your question, if you feel like treating membranous, having ruled out malignancy with immunosuppressive agents, go on and treat, because you don't want the patients to progress, you don't want the nephrotic, and then keep an eye on malignancy. So you cannot deprive the patient from immunosuppression just in case he has a malignancy that you haven't discovered yet. But bear it in mind. Can I ask the audience, how do you screen for malignancy in older patient with Professor Fogazzi? Come and sit with us. Saves me bring the microphone to you every 2 minutes. That's the microphone.
Over the age of 50, we chest X-ray, we ultrasound of the abdomen, and colonoscopy to everybody, in spite of the lack of blood in the feces. This is what we do, and all the serological markers for, of course, of cancer. And if the patient is
colonoscopy for everybody.
Yes, for everybody. And if the patient is a lady, gynecological investigation.
So the fifth question of my 5 whats is the cost-benefit analysis of colonoscopy for everybody. How often do you find a colonic tumor?
Yeah, that is a good question. Most of the time, 99.9% of the times, we don't find anything. But, you know, in order to answer in some way to the previous question, it is always very challenging, you know, and we have a high proportion of elderly patients now who come with nephrotic syndrome. So it is very important to us to be sure that we are not treating a manifestation which is secondary to the tumor. So we think it is better to be a bit invasive rather than to miss a cancer or a tumor.
Thank you. Professor Hass, yeah, sorry.
I had a question for everybody, and also for the experts. How many times have we seen a nephrotic syndrome reversing spontaneously in 6 months? Because this is another thing which is in the guidelines, which make me a bit surprised. I've seen many patients with nephrotic syndrome associated with membranous nephropathy. We were convinced by our boss to wait for 6 months in order to comply with the guidelines. I've never seen a patient with a reversal, a spontaneous reversal of the nephrotic syndrome associated with membranous nephropathy. What is your experience?
There are many publications. I mean, it goes back to Riginetti and Remuzzi, 30-30-30. 30% go into complete remission, 30% go into partial remission, and 30% do not respond. And there are even more recent publications showing that you can get into remission up to 12 months. Can't remember who from. Did you see? I can't remember. Did you see spontaneous remissions?
Well, I will share with you, but I won't go that far. I think we see those cases, and I think there is some biopsy markers for that. But I share with you the concern that the idea of the 30-30-30 is probably underestimating the reality.
Yeah, what about your personal opinion?
It's difficult to say because we put them all on an ACE and an ARB. So invariably they have decreased, well not invariably either, but some of them have decreased proteinuria on an ACE and an ARB and a diuretic. So it's difficult to tell. Mark, do you have any personal? I would say that some, I guess, would go into partial remission spontaneously. But what does spontaneously mean when you treat them with an ACE and an ARB and statins and all that? Dr. May?
No, personally, I don't wait.
You don't wait?
No.
Okay.
Because she doesn't
I don't wait.
So what do you do straight away? You give them endoxan and
For 1 or 2 months and yeah.
endoxan and steroids. Okay.
Or maybe cyclosporin. What's the case of cyclosporin in our case?
What's the case for cyclosporin? I think you felt that it was Ahlan ya Hany. Hi, come and join the panel. So you felt that it was a young woman and she has lost a lot of kidney function and you wanted to be more active than just giving a CNI or a proteinuria suppressor.
CNI as a routine to give to her, the GFR will decrease. This is almost guarantees, and if you look up the literature of cyclosporin, the relapse rate would be higher. Okay, and I think there is, let me share 2 comments on the mycophenolate, which is important. Actually, it's now, it used to be in discretionary use to use mycophenolate in Canada, but now it's approved for all form of GNs. And it's an amazing, if you hear Dan Catherine, for example, he believes that GNs across continents have different probably etiology. So what we see in the kidney may reflect something different. So we tend to be a little bit more of a believer on the MMFs compared to the CNI as a start. And again, we have to remember that we may have to use cyclosporin. It's not, I'm not saying it's against it, but I won't start with it in someone like this.
Shall we move on? We've only got half an hour and I've got a lot of questions from the audience. Just a quick word about plasmapheresis to build on what Professor Shukra said. In the Middle East, you see more severe and aggressive lupus and lupus nephritis that we certainly do in the UK. We don't see many lupus in the UK. You use plasmapheresis in aggressive cases in Egypt. Is that right? Yes or no? Who uses plasmapheresis in aggressive SLE? Hany, would you like to comment? Because again, not the guidelines, but the guidelines don't recommend it, and the literature don't support it, but you use it, different genotypes or phenotypes.
The alternatives present when we are faced with aggressive lupus are in the range of trial of rituximab, in which there is also no much evidence, or the new drugs like the anti-bliss. So most of these are not yet available widely in Egypt. So what we are doing whenever we are confronted with such a resistant case, if we don't have a facility for rituximab, we give a chance for plasmapheresis.
Thank you. I've got an interesting case to stay on the lupus in Egypt theme. You have a lot of HCV in Egypt, and you have a lot of lupus in Egypt. So how do you treat active hepatitis C in a patient with lupus? Question from one of our young colleagues. General principle, you've got a patient with lupus. Lupus is quiescent. And you've got now hepatitis C with high PCR count. What do? Do you give them pegylated interferon and ribavirin, normal kidney function, or? لا creatinine 1.5 مثلا. But now the lupus is non-active. The patient finished the immunosuppression, not on steroid and Cellcept anymore, بس الهepatitis activated.
So you treat the lupus when the lupus is active, and you treat the hepatitis when the hepatitis is
So treating the hepatitis as you would treat any hepatitis بصرف النظر ان عندها lupus, الانترفيرون هل بيعمل activation? No. Professor Amin Suleiman.
If the kidney is active, we'll give the immunosuppression under umbrella of the treatment of hepatitis interferon. And on the other hand, if the hepatitis is calm and the kidney is is active, it have to take time and start immunosuppression without the umbrella interfere. We have the three possibilities according to the situation. So every case is tailored according to its circumstances. Okay.
I just wondering how would you classify the renal activity, whether it's due to the lupus or to the HCV? This is always a very important point to bear in mind. If the patient is an active lupus and she's a class 4, and if the patient is, and on the other hand, it's sometimes you cannot know if it's not a cryoglobulinic MPGN.
For example, you see that the kidney is aggressive. For example, the creatinine is like 1.5, 3.5, something aggressive. The kidney will be lost. The kidney must be aggressive. You have to give immunosuppression, short steroid, and something aggressive. But without giving the interferon, you be afraid of the dogmas. So it depends on the case.
I think we have an experience with this interferons and hepatitis C, etc., etc. I think first of all, hepatitis C is a very variable disease. Can be very severe, can be very slow, can depend on the different conditions. Second, our experience with interferon was very frustrating. The response rate is low. The cost is very high. And the complications are also very high. So we stopped completely the treatment with interferon. I disagree with the KDOQI guidelines about that. Absolutely. The only thing we found in our study, we did a subtyping of the different type of viruses in the hepatitis C. And it turned out that some types were more sensitive, but this is far away from very well clinically demonstrated.
The main phenotype or genotype in Egypt is 4. Yeah. And the one in Europe maybe 1 or 2. Okay.
Actually, I was about this question because my thesis was about lupus. We saw about 210 cases over 3 years. I was faced with similar case, but the opposite phase. We were dealing with lupus cases. This case was diagnosed primarily as cryoglobulinemia without evidence of cryo, and we accidentally discovered the presence of lupus. We thought the biopsy was mesangiocapillary glomerulonephritis. That was our first diagnosis to be cryo. But when the serology results appeared to have highly active lupus, we started pulse steroid, then we started the patient on interferon, and she did well actually.
Thank you.
I think it is a risk benefit. Hepatitis C virus will not bring the patient to this, in spite not giving interferon for him. But when lupus bring the patient to this from cerebritis or anything or loss of kidney, so we didn't give interferon, which may flare lupus and will not give us many benefits. On hepatitis C virus will, with complication, will appear after 20 or 30 years.
I would like to have a few comments. The first, in Egypt, we have type 4, which has a better response to interferon than type 1, which is present in combination with ribavirin. The response, yeah, 40%, up to 40%. Maybe with addition of the new drugs for anti-hepatitis C, the percentage increases up to 60%.
With the protease inhibitor?
Yes, with the protease inhibitor. This is the first comment. The second comment, there was a trial, I think it was in Mayo Clinic, of using rituximab in the management of hepatitis-induced nephritis. And this could be a link between the lupus and the hepatitis C, because we just mentioned that rituximab could be one of the lines of management. So a trial, if it is aggressive hepatitis C, of giving rituximab could be justified also.
This was the next case. We might as well move on. One of our colleagues, patient with hepatitis C-induced cryoglobulinemia and mesangiocapillary glomerulonephritis, who for cardiac reasons is intolerant to interferon. For anemia reason, she doesn't want to give her ribavirin. The question is what to give. You've got the virus and you've got the nephritis. So you will give rituximab. Okay.
Or if I have access to an anti-bliss, maybe I will think to get it. Huh? Belimumab.
You told me about
Belimumab.
this case. Just remind us if there's anything I missed.
Presented by proteinuria, membrane proliferative glomerulonephritis, coming to us by flaring with vasculitic lesion on all that skin of the patient, and proteinuria about 1.5 gram per 24 hour. The patient firstly take corticosteroids, but the patient sometimes discontinue the treatment by himself, presented by dyspnea or sopnia, anemia. The anemia is very aggressive. Patient may his hemoglobin 10 after 3-4 days, maybe 4. The line of treatment to this patient, what?
As you are mentioning, this drop of hemoglobin from 10 to 4, you should first think of any either autoimmune hemolytic anemia as a part of the lupus complex, or bleeding somewhere, maybe a complication from steroid given at any time. But I would here think of giving this Benlysta, which is the belimumab, according to the FDA. In 2011, it has been introduced in the armamentum of management of lupus, and I think it could be. It doesn't have any cardiac hazard if you are speaking about cardiomyopathy. In the same time, it will not exaggerate the anemia as the idea of having ribavirin in this patient, and the interferon would be very, very weak in such a case.
What is the evidence that belimumab works in membranoproliferative glomerulonephritis? There's no data.
There is no evidence yet. There is no evidence. We don't have evidence, but yes, but there are trials of using it in lupus nephritis, and it has been approved in this by the FDA in 2011.
Why don't you use more commonly used agents? Why don't you
rituximab?
Use rituximab?
Rituximab, of course.
Because you have more experience
yes.
of rituximab than belimumab.
Rituximab?
Belimumab before?
I don't know. But I recommend, because in the literature it is promising.
Okay.
But rituximab, we used it in Egypt many times.
Okay. To stay on the rituximab theme, our colleague from Gaza has a patient with active lupus who's intolerant to cell-set, intolerant to azathioprine. So he managed to induce remission with 4 injections of rituximab. The patient now is quiescent, nephritis is controlled, creatinine 1.5, normal. And the question is how to maintain the remission. You can't give Imuran, you can't give cell-set, so do you give low-dose rituximab every 4 months, every 6 months? Dita, that's what you suggested?
We have discussed already this case yesterday, and this is the experience we have had. I had personally with the patient with venous granulomatosis. So we gave her, for a very bad lung involvement, a full course, and then we followed up the patient without doing nothing, with just a bit of corticosteroids. And of course, the disease relapsed twice. So at the end, together with the lung specialist, we went through the literature carefully. And what we have decided to do after reviewing the literature and reviewing carefully our own case, we decided that to give at fixed time over the year 1 injection of rituximab, 1 every 4 months, without waiting for the increase of ANCA titer, without the appearance of symptoms. This is, I think, the best way we have to check patients like those. You know, they are refractory or they have contraindications to other therapies. And what you can do is to give a immunosuppression at fixed times. This is the only thing I have in mind, but after reviewing the literature, however.
Nephrologists like fashion. You know, they like ACE inhibitors 20 years ago. It's fashionable. Now nephrologists like rituximab. And if you come anywhere near a nephrologist for a year, you bet your bottom pound you'll get rituximab. Aren't you worried about the toxicity of this drug? Progressive multilocal encephalopathy, and especially immunosuppressive, very rare.
I can give you our own experience. We were very reluctant in starting giving rituximab to our patients. You know why? Because the first two patients treated, one died for lung infection, and the other one ended up in ICU for 3 months.
We had horrible pneumocystis as well in our transplant, 2 last year, after antibody-mediated rejection treated with rituximab.
Dr. Abdelmajid, could I ask your opinion about use of calcineurin inhibitors in these cases? Because there is a wave now of introducing calcineurin inhibitor in lupus patients.
So the patient is in remission, normal renal function. To be honest, I probably wouldn't do anything. I probably would leave him or her alone, follow him or her up, follow the serology and see what happens. When the complement starts going down on the serology, I would not treat the serology, but it will alarm me that he or she may be reactivating soon, and then I'll think about what to do next. But yes, CNI is an option.
Well, I definitely, you scare me basically by the way how we look at rituximab. We are quite careful of its use. I think we have to be careful. It's easy to talk about we're giving the patient now, and then 5 years you don't know what will happen. What we think forward a little bit. So lacking a data really in a controlled way, and I know lupus is a rare disease and so on, I would at least be hesitant to use it until it's the last resort. I would not assume it's safe. I would not.
Maybe you have more evidence for its use in vasculitis than for lupus. It's not very.
The evidence in lupus is weak. I mean,
Yeah.
the LUNAR study was inconclusive. In ANCA-associated vasculitis, 2 major trials of rituximab, the RAVE International, which is the American one, and the UVAS one from David Jane in the UK and Europe. And they were both as efficient as cyclophosphamide and steroids, so not negative, but not superior to.
Only relapsing vasculitis.
Yeah, in the relapsing one, the European one, they felt that there may be an advantage for rituximab. And David Jane and the Cambridge people would say they would use rituximab in relapsing ANCA-associated vasculitis.
But we don't have to forget that we are speaking about borderline patient, a difficult patient, not a common patient. As was not common the patient I was following after for a very bad lung disease. For some patients, I think we cannot wait that the recurrence appear because at times it is too late. Or maybe you have a flare-up with acute lung disease which will transform in something chronic. And then you will have another relapse which will, in the long term, will make the situation very, very, very difficult.
We have to remember that plasmapheresis and IVIG is at least not associated with significant immunosuppression, and I think we should remember this. That's what I would do before using rituximab. I think I'm not disagreeing more than just because it's a teaching session, so I don't want basically students to leave and think that anybody who doesn't respond in a month or 2, give them just rituximab. Just be careful, that's the point. But obviously we have to. But we use a lot plasmapheresis in those kind of atypical severe form, particularly lungs. And IVIG with plasmapheresis remains good supportive therapy.
That's what I suggested to the cryoglobulinemia HCV intolerant to plasmapheresis for the cryoglobulinemia and the vasculitis associated with the cryoglobulinemia, and IVIG at the end for 5 or 6 days, which will also take care of the hepatitis perhaps. And switch off the autoantibody perhaps.
And that's grade, actually grade 1A. If you look at the cryos, plasmapheresis plus or minus IVIG, but plasmapheresis. So cryos, number 1, you have to plasmapherese them. And although I knew it, we had a case, it happened to be basically CV, which we don't usually get much. But when we reviewed the data at the time, it's actually, the data is extremely strong. So it has to be there from the start. If you have cryos, I don't know how aggressive use it, but we do. Mind you, we have few cases, you have lots.
Perhaps thank you. 5 more minutes before Professor Dubro's lecture, I think next on the program. On glomerulonephritis or vasculitis, any cases, any questions?
I want to ask about focal segmental glomerulosclerosis. Patient treated for a few years with cyclosporin and steroids with no response, and Cellcept 1 gram added to the regime. After 1 year, complete remission. This was due to combination therapy or just due to Cellcept alone? But I think she was forgotten to stop cyclosporin or...
FSGS, just a plea about FSGS, make sure it's primary. Every FSGS I see sometimes out of 10 or 20, they tend to people with reflux, people with chronic GN, people with all sorts, pamidronate induced and so on. So the histopathologist will tell you focal segmental glomerulosclerosis, but will not specify primary or secondary.
So please know that if the report came to you and the diagnosis with focal segmental glomerulosclerosis, that does not mean that this is primary FSGS or that this is idiopathic FSGS or that this is a license to immunosuppress the patient. You're the ones who are seeing the patient, so yes, you need to know if the patient has reflux, if he's a diabetic patient, if a hypertensive patient, and 40 something, and so on. So not every focal segmental glomerulosclerosis is a pattern. It means glomeruli are sclerosing, and it does not equal to idiopathic FSGS.
So the treatment of choice according to the guidelines, 6 to 8 weeks of high-dose steroids, which is almost ridiculous because you probably kill more patients than treat. They recommend 60 to 80 milligram for 8 to 16 weeks, something like this, which is really heavy. And then CNI, which will be the second-line treatment. Cellcept doesn't seem to be very effective in FSGS, or at least in my experience. May, any comment on Cellcept? Calcineurin inhibitor, high-dose steroids, and you have to combine the two, ACE and ARBs.
In this case, the thing that makes difference with the
Yeah.
Just stop cyclosporin and start Cellcept, or was added and with good effect?
Right.
Yes.
Yeah.
Pure now.
Okay.
No protein.
Right. And he or she didn't respond to steroids plus CNI alone.
When I saw her, she was 5 years cyclosporin.
Okay.
Not those high.
I see a lot of FSGS treated with Cellcept, don't get me wrong, but usually to no effect. So obviously she is lucky.
By the way, in the other presentations you have the actually if you do guidelines, there's a lot to be said about the FSGS with all the criteria of secondary and fourth.
Primary, secondary, different subtypes, the 5 histological subtypes. Would you like to remind us of the 5 histological subtypes of FSGS?
Yeah, sure. They are morphological subtypes, which still debatable, the prognostic values, or some of them we know that they do carry a poor prognosis. We have focal segmental glomerulosclerosis, NOS, or none otherwise specified, where you just see almost more than 40% of the glomerulosclerosed. Then we have the tip lesion, meaning that you will have hyalinosis and sclerosis in the tip. We consider the pole of the glomerulus where the arterioles are entering, so the point across it will be the tip, and so this is the tip variant or the tip lesion. This is one of the most debatable lesions about its prognosis. Every now and then we say it has a better prognosis, then worse prognosis, then again better prognosis, and so it's not settled. Then we have the collapsing variant, and this collapsing variant, you need the tuft to be collapsed and the epithelial cells to proliferate. So also because this is also a common misinterpretation. If you have glomeruli usually collapse due to ischemia. This is a common finding in biopsies. So it doesn't mean that the pathologist is writing to you that the glomeruli are collapsed. That means that the patient has a collapsing FSGS. Collapsing FSGS carries certain criteria and requires and we do not see it that commonly actually here in Egypt. Then we have the cellular variant, a very rare variant, again a debatable variant, and the most concluded upon is that this is probably precedes the sclerotic phase. So this is cellular proliferation, which is before the sclerotic phase. However, in this variant, it looks exactly like focal proliferative. You can have neutrophils, you can have proliferation, and it's quite a rare thing. And then, as I said, you have the classic or the perihilar variant, which is the commonest one we see secondary to hypertension, and you have the hyalinosis and sclerosis around the arteriole.